Hello, everyone. Our topic today is about fever, sweating, and hot flashes. Objectives: we're going to go through these three topics: the fever, sweating, or night sweating in particular, and hot flashes. Introduction: fever, sweats, and hot flashes are commonly encountered in the terminally ill and cancer patients. These may sometimes be associated with considerable morbidity and mortality. Although infection remains the most common etiology of fever in patients, irrespective of whether they are receiving chemotherapy or not, fever is commonly seen in patients with absence of infection as well. Fever is also one of the most common symptoms experienced by elderly people at end of life. Similarly, hot flashes are reported by the majority of menopausal women, and in some women can be a major source of distress. Less well recognized is the impact of hot flashes on individuals with cancer, particularly women with a history of breast cancer and men with prostate cancer. In women with a history of breast cancer, approximately two-thirds experience hot flashes. Fever is defined in Stedman's Medical Dictionary as a complex physiologic response to disease, mediated by pyrogenic cytokines and characterized by a rise in core temperature, generation of acute phase reactants, and activation of immune systems. More commonly, fever is defined as the elevation of the core body temperature above normal. Normal average adult core body temperature is 37 or 37 degrees centigrade or 98.6 Fahrenheit and displays the circadian rhythm, with the body temperatures being the lowest in the pre-dawn hours at 36.1 or 97 Fahrenheit or lower, and rising to 37.4 or 99.3 Fahrenheit or higher in the afternoon. In oncology practice, a single reading of temperature of more than 38.3 or three readings, each taken at least an hour apart, of temperatures more than 38 is considered significant. Pathophysiology of fever. Well, integral um, to this process of fever, hypothalamus functions most like a thermostat, balancing heat production and heat loss. Fever is also considered an immune system activation, resulting in a regulated rise in body temperature. The regulation of this phenomenon is accomplished by the actions of two types of endogenous immunoregulatory proteins called cytokines, some functioning as pyrogens and others as antipyretics. A number of exogenous substances, often referred to as exogenous pyrogens, have been found to be capable of evoking fever in animal models. One of these is the lipopolysaccharide, or LPS, a cell wall product derived from gram-negative bacteria, has been the most extensively studied. Exogenous pyrogens induce the production of pro-inflammatory cytokines, such as interleukin-1b and interleukin-6 and interferon alpha, and tumor necrosis factor, which act as the humoral mediators influencing brain structures involved in resetting the hypothalamic set point. Cytokines are thought to exert their effect on the brain via direct and indirect mechanisms. So again, we return back to the hypothalamus. Okay, the hypothalamus is the center that regulates heat production and heat loss. And these mediators are, in fact, affects this, hypothalamic set point. It resets the hypothalamic set point. So again, peripherally produced cytokines reach the central nervous system directly by crossing the leaky areas in blood-brain barrier via circumventricular vascular organs, which are basically networks of enlarged capillaries surrounding the hypothalamic regulatory centers. In disease states such as bacterial infections, the blood-brain barrier can be compromised further, leading to an influx of cytokines from the periphery. Although not fully understood, it is proposed that cytokines stimulates the central production of the inducible enzymes COX-2 and thus the role of COX-2 inhibitors in reducing the temperature or the fever. Another mechanism, by which peripherally produced cytokines communicate with the brain include the stimulation of terminal fiber of the autonomic nervous system. Norepinephrine is the principal neurotransmitter, although there are several others have been implicated as well. Okay, this picture kind of give you an idea how things happen in your body here. You have the infectious agents, toxins, mediators of inflammation. This stimulates the monocytes, macrophages, endothelial cells, and other immune cells. Release pyrogenic cytokines such as interleukin-1, interleukin-6, and interferons. And this stimulates the anterior hypothalamus mediated by the prostaglandins. And in particularly, this is the area where the NSAIDs and antipyretics work. This will elevate the thermoregulatory set point, and then this will increase the heat conservation by doing vasoconstriction, behavioral changes, increase also heat production by involuntary muscle contractions, and this will eventually lead to fever. Again, this is another nice picture for what happens in the hypothalamus. Behavior changes, heat loss mechanisms, and the posterior hypothalamus, works on the heat gain mechanisms and behavioral changes that will increase your body temperature. So we have two parts of the hypothalamus here, anterior and posterior hypothalamus. All the information go to the anterior and then it goes to the posterior. The anterior part is the one responsible for the heat loss, while the posterior part is the one, responsible for heat preservation. Etiology of fever: blood transfusion reactions, CNS metastasis, drug-associated etiologies such as cytotoxic agents, antibiotics, interferon, infections, radiation-induced fevers, thrombosis, and paraneoplastic phenomena. Again, causes of fever. Infections. Nearly two-thirds of cases of fever in patients with prolonged neutropenia may be attributed to infections, a major cause of morbidity in patients with cancer. Fever in a cancer patient should be considered indicative of infection unless proven otherwise, with appropriate assessment being instituted in a timely fashion. Febrile neutropenic patients' absolute neutrophil count less than 500 per millimeter cube represent an absolute emergency. In patients with advanced Alzheimer, physical consequences of progression of dementia predispose them to infection and fever, especially to aspiration pneumonia, urinary tract infections, and decubiti. Paraneoplastic fever. Malignancy is often found during the workup of patients presenting with fever of unknown origin. A later study reported malignancy as the cause of fever in 15% of patients. In patients with cancer presenting with fever of unknown origin, paraneoplastic fever was found to be the most common etiology. Although the exact mechanism of tumor-associated fever is unclear, it is thought to involve inflammatory cytokines, such as tumor necrosis alpha, interleukin-1, and interleukin-6, which are produced either by host macrophages in response to the tumor or by the tumor itself. Tumor cell, inflammatory cytokine, necrotic tissue, inflammatory cytokine, such as interleukin-1 and 6, tumor necrosis factor, and interferon. And also, this will eventually increase your prostaglandins that will affect your hypothalamic set point. And these mediators will affect the liver producing CRP, which is a marker of inflammation in your body. Paraneoplastic fever. Fever may be a common presentation for some malignancies, and the progression may parallel the occurrence of fevers. Although Hodgkin's disease has classically been associated with Pill-Epstein fevers, Pill-Epstein fevers are recurring periods of fever lasting for 3 to 10 days at a time. Several other malignancies have been associated with paraneoplastic fevers and include acute leukemias, lymphomas, renal cell carcinomas, bone sarcomas, adrenal carcinomas, and pheochromocytomas. Solid tumors such as breast, lung, colon are less often associated with paraneoplastic fevers. However, the presence of liver metastasis from these tumors may result in fever. In addition, any solid tumor can cause obstruction, can result in fever. Pill-Epstein fever. Blood transfusion can also cause fever. Transfusion-associated fever. In a large retrospective study, the incidence of side effects following transfusion of 100,000 units of packed red blood cells to more than 25,000 cancer patients over a 4-year period was found to be only 0.3%. And these are some of these transfusion-related fevers. The first one is febrile non-hemolytic transfusion reaction, 51.3%. Allergic urticarial reactions, 36.7%. Hemolytic reactions, 17%. Bacterial infection. The prevalence of bacteria estimated to be only 0.04 to 2%, especially in platelet concentrates. The incidence of bacterial contamination in red cell concentrates is much lower and almost zero for fresh, frozen plasma, and cryoprecipitate. Fever due to underlying disease. Evaluation of fever. Assessment of fever requires a careful study of history, medication review, and a thorough physical examination. To include all major body systems. In nearly two-thirds of neutropenic patients, the initial evaluation might not identify the focus of infection. Signs and symptoms of fever. Runny nose, sore throat, joint pain, muscle pain, sore eyes, cold sores, rapid heart rate, dizziness, shivering, pale skin, sweating, fatigue, and infections. Specific interventions. The presence of a fever may be associated with the potential metabolic consequences, such as dehydration, increased oxygen consumption, and metabolic rate, which may be especially pronounced in debilitated, terminally ill patients. If prolonged, fevers may be associated with increased nutritional demands and debilitating fatigue. Although fever may be beneficial for enhancing host defense, other factors as the patient comfort and physiological responses also deserve consideration. Suppression of fever may help alleviate uncomfortable constitutional symptoms of fatigue, myalgias, diaphoresis, and chills. In addition to constitutional symptoms, focal findings related to the etiology of fever may also contribute to symptom burden. For example, abscess formation is often associated with pain, while uncomfortable dyspnea and cough can be related to pneumonia. Patients with advanced cancer may opt not to treat the underlying etiology of fever and seek only nonspecific palliative measures. For patients who can communicate, it might be beneficial to be certain that if the fever is uncomfortable and whether curing the fever is more uncomfortable than the fever itself for the patient. Although empiric, there is no compelling reason to think that the treatment of fever actually reduces suffering for dying unresponsive patients. This is an extremely important point of this presentation. We all treat fever, but in fact, we don't have enough evidence to think that the treatment of fever actually reduces the suffering, especially if you have a patient that's dying and unresponsive. Aggressive treatment of infection doesn't improve survival rates among persons with severe dementia, and in fact, it has been associated with accelerated progression of the severity of the dementia. Antibiotics and other aggressive measures are often associated with numerous deleterious outcomes, including renal failure, ototoxicity, allergic or drug reactions, rash, diarrhea, blood dyscrasias, antibiotic resistance, use of intravenous lines, and mechanical restraints. Non-specific interventions. During febrile episodes, increasing fluid intake, removing excess clothing and linens, tepid water bathing or sponging, and use of antipyretics may offer relief. In very sick patients, administration of fluids intravenously or subcutaneously might be warranted. connective cooling via increasing air circulation by fans or using an airflow blanket may be effective in reducing temperatures and improving comfort. Fever control may be enhanced by combining physical methods with antipyretics. Comfort was greatest in children receiving acetaminophen combined with tepid water sponging. Discomfort was found to be greatest when sponging with ice water or isopropyl alcohol or with or without concomitant administration. So it's better to combine an antipyretic with a physical method. Cold sponging, like acetaminophen, aspirin may be effective in reducing fever, but should be used with caution in patients with or at risk of thrombocytopenia due to its antiplatelet effects. In children, aspirin use is contraindicated due to the risk of Reye syndrome with fever related to certain viral etiologies, including varicella and influenza. NSAIDs should be used cautiously in cancer population because it might inhibit the platelet function and may also cause gastrointestinal hemorrhage and adversely affect renal function. Some of the most famous antipyretics. Again, if you're going to use antipyretics, especially NSAIDs, use them cautiously and make sure that you check your renal functions before you administer them. Check whether patient is having any type of allergies to NSAIDs or not, and try to use them for a limited short of time. This is not something that the patient should take forever. Limit it to 1 week, 2 weeks, and that's about it. So you don't start to get the side effects of NSAIDs. This is how NSAIDs work, and even steroids can do the job in cases that you don't want to give an NSAID to the patient, because in fact it actually affects the pathway early on by blocking the phospholipase enzyme here. The cyclooxygenase works here, blocking the cyclooxygenase enzyme. The NSAIDs block the cyclooxygenase, steroids block the phospholipase, and thus the steroids reduces both the cyclooxygenase and the lipooxygenase pathways. Primary interventions. Patients should be instructed to seek medical help if fever develops when neutrophil count is low or declining. In febrile neutropenic patients, broad-spectrum antibiotics should be initiated immediately, even before cultural results are available, as mortality could be 70% for patients not receiving antibiotics within 48 hours. Treatment regimens are further modified by the duration of the fever and individual patient risk factors, such as the presence of central lines or other artificial devices, history of steroid use, and history of injection drug use. After a specific pathogen is isolated, antibiotic therapy is then changed to provide optimal therapeutic response. The single most important determinant of successful discontinuation of antibiotics is the neutrophil count. If the infection is not identified after 3 days of treatment, if the neutrophil count is more than 500 for 2 consecutive days, and if the patient is afebrile for more than 48 hours, antibiotic therapy may be discontinued. For neutropenic host persistent recurrent fevers, after 1 week of broad-spectrum antibiotic, the addition of antifungal agent is recommended, as continued granulocytopenia is usually associated with the development of non-bacterial opportunistic infections, particularly candidiasis and aspergillosis. Acyclovir is the drug of choice in the treatment of herpes simplex or varicella zoster viral infection. Ganciclovir has activity against cytomegalovirus. Both agents can be used prophylactically in the management of patients at high risk for these infections. Acyclovir and ganciclovir. Paraneoplastic fever. The best management for paraneoplastic fevers is the treatment of underlying neoplasm with definitive anti-neoplastic therapy. If not possible, NSAIDs have been considered as the mainstay of treatment, with naproxen being the most extensively studied one. However, indomethacin and diclofenac has been also found to be effective. Several studies have suggested that neoplastic fevers are more responsive to NSAIDs than infectious fevers, leading to the advocacy of naproxen tests to differentiate between neoplastic and non-neoplastic fevers. Thalidomide is an immunomodulatory agent, has been shown to have modulatory or suppressive effect on several cytokines such as tumor necrosis alpha, interleukin-1 and interleukin-6, all involved in paraneoplastic fever, which theoretically may have a role in the treatment of cancer patients with fever and sweats. Naproxen, thalidomide. Transfusion-related fever. Many institutions have moved towards leukocyte-reduced transfusion in an effort to decrease the incidence of these FNHTR, and several countries have been restricted and manufactured transfusion of blood products to pre-storage leukodepleted blood components only. The decreased incidence of the FNHTRs with leukoreduction has been found in many studies. The use of erythropoietin for cancer-related anemia may decrease the need for blood transfusion and may be used for cancer-related anemia. The risks versus benefits, including the cost of such prophylactic treatments to avoid or delay transfusions, needs to be carefully reviewed, as they are not devoid of side effects, including reduction in survival. This is basically on the left, the leukoreduction filter. Standard leukoreduction filter. Pink filter is used to filter red blood cells, and white filter is used to filter platelets. Epoetin, or we call it EPO, can be given subcutaneously or IV. Drug fever. Drug-associated fever responds to cessation of the offending agent when possible. Response to fever and related symptoms with biological response modifier administration is type, route, dose, and schedule dependent. These factors may sometimes be altered for fever control without compromising with efficacy. Liposomal amphotericin B is as effective as conventional amphotericin B for empirical antifungal therapy in patients with fever and neutropenia, but is associated with decreased toxicity, including the occurrence of fever and chills. We have liposomal amphotericin B, and we have also another agent, caspofungin acetate. Caspofungin has also shown promising results. Fever may be attenuated by the use of acetaminophen, NSAIDs, or with or without steroid pre-medication. It's a common clinical practice to administer meperidine to attenuate severe chills associated with febrile reaction, although empirical data confirming its efficacy are not available. Liposomal amphotericin B and caspofungin acetate. Hyperthermia. Although in the vast majority of patients an elevated body temperature usually represents a fever, there are instances where elevated temperatures could be secondary to hyperthermia. These include heat stroke syndromes, certain metabolic diseases, and drugs that interfere with thermoregulation. With fever, thermoregulatory mechanisms remain intact, but the hypothalamic thermal set point is raised by exposure to endogenous pyrogens, leading to behavioral and physiological responses to elevate body temperature. In contrast, during hyperthermia, the setting of thermoregulatory center remains unchanged at normothermic levels, while body temperature increases in uncontrolled fashion and overrides the ability to lose heat. Hyperthermia thus results from an overwhelming of the peripheral heat dissipating mechanisms by disease, drugs, or excessive heat, whether it's external or internal. In patients diagnosed with hyperthermia, physical cooling should be started immediately, such as removing bedclothes, sponging the patient with tepid water, and using bed fans. More rapid reductions in body temperature can be achieved by sponging the patient with alcohol or by using hypothermic mattresses or ice packs. Immersion in ice water is the most effective means of physical cooling, but it should be reserved for truly hyperthermic emergencies such as heat stroke. In true emergencies, treatment also include intravenous or intraperitoneal administration of cool fluids, gastric lavage or enemas with ice water, and even extracorporeal circulation. No matter what technique is used, body temperature must always be monitored closely to avoid hypothermia. So this is nice, stable, compares the fever with hyperthermia. So here in fever, the temperature adjusting point is higher than normal, but it's normal in hyperthermia. Thermoregulation is normal here, but it's impaired in hyperthermia. So this is very important as far as the mechanism. The symptoms depend on the stage. Does not depend on the stage, but the severity increases with time. Role of organism, both positive and negative. Only negative. Treatment, antipyretics is the mainstay of treatment, but in hyperthermia, it's the physical cooling. These are some of the drugs that can increase your temperature, okay, causing hyperthermia, uh, uh, such as drugs that can cause serotonin syndrome, okay, anticholinergic syndrome, neuroleptic malignant syndrome, and malignant hyperthermia. Night sweats. Night sweats, patients presenting with night sweats warrant a detailed evaluation. Compensatory hyperhidrosis can usually occur in normal sweat-producing skin in response to anhidrosis in other areas of the skin. The prevalence of sweats and their impact on quality of life in the cancer population is now well established. In patients with advanced disease or those receiving palliative care, the prevalence of sweating or hyperhidrosis ranges from 14 to 28%. It's frequently nocturnal. Nocturnal diaphoresis or night sweats and is moderate to severe in intensity. Although the night sweats have been defined as drenching sweats that require the patient to change bedclothes, this definition might not describe the majority of patients who complain the symptom. In the literature, night sweats has been associated with a variety of medical problems such as lymphomas, infections, TB, autoimmune disease. Common malignancies associated with night sweats include lymphomas, leukemias, renal cell carcinomas, and Castleman disease. The classic presentation of TB include fever, weight loss, and night sweats. AIDS-related infections might also cause night sweats, such as Mycobacterium avium complex and CMV syndromes. Causes of night sweats. We have a long list here. Last topic is the hot flashes. Hot flashes is experienced by 3/4 of menopausal women and is described as a sudden onset of uncomfortable sensation of intense heat, accompanied by skin flushing, warmth, and sweating, usually the chest and the face. Hot flashes typically last for 2 to 4 minutes and often accompanied by palpitations and anxiety, and may be triggered by emotional stress, anxiety, alcohol, and certain foods. Approximately 2/3 of women with a history of breast cancer experience hot flashes. In postmenopausal women with a history of breast cancer, predictors of hot flash severity include the higher body index, a high school education or less, younger age at diagnosis, and tamoxifen use. For patients starting tamoxifen, hot flashes typically increase in the first 2 to 3 months, followed by a plateau and then gradual dissipation. A hot flash is a sensation of intense heat that can also cause sweating and heart palpitations. Causes of hot flashes: abrupt menopause, chemotherapy, radiation surgery, cancer type, breast and prostate cancers, early menopause, ethnicity, African women, Western women, lack of exercise, high body mass index, low education, low estrogen level, low socioeconomic status, and smokers. The prevailing hypothesis relating to the development of hot flashes to lowering of estrogen level, leading to complex neuroendocrine mechanisms, including alterations in the level of hypothalamic neurotransmitters, which resets the thermostat to a lower level with a narrower range as compared to those who do not experience hot flashes. Most recognized neurotransmitters involved in this hypothalamic thermoregulatory processes are norepinephrine and serotonin. And this has a clinical implication, guys, when it comes to the treatment of hot flashes. Hot flashes should be routinely assessed as a component of systematic symptom surveys, and if present, a careful assessment of hot flash frequency, intensity, duration, and potential triggers, and the impact on quality of life is advised in order to construct an individualized treatment plan. Symptoms of hot flashes: sudden warm sensation, feeling very hot followed by feeling chilly, dizziness and headache, increased heart rate, and excessive perspiration. Treatment interventions for hot flashes: hormonal agents, androgens, estrogens, progestational agents, non-hormonal agents such as alpha adrenergic agents, antidepressants, beta blockers, gabapentin, vitamin E, CAM therapies, herbal medications, acupuncture, and behavioral interventions. Estrogen replacement is an effective treatment for hot flashes in 80 to 90% of patients, regardless of the underlying etiology. However, some women have absolute or relative contraindications to hormonal replacement therapy, and others are reluctant to take hormones due to the perceived risks and side effects. Observed benefits of hormonal replacement therapy on hip fractures and colon cancer risk were far outweighed by increased risks of venous thromboembolic diseases, breast cancer, stroke, and coronary artery disease. So these are basically the pros and cons of giving estrogen. The hormonal cause of hot flashes: estrogen withdrawal, decreasing circulating endorphins and catechol estrogens, increased serotonin norepinephrine release, lowering of thermoregulatory set points. This will end with hot flashes. Progestational agents have comparable efficacy to estrogens for hot flash reduction. Agents studied include megestrol, transdermal progesterone, medroxyprogesterone acetate. Despite the benefit of amelioration of hot flashes, it's still there's an ongoing debate about the safety of these drugs in patients with breast, uterine, or prostate cancer. Tibolone is a synthetic steroid compound with combined estrogenic, progesterogenic, and androgenic properties. Has been reported to reduce hot flashes. This is not available in the United States, Tibolone. Megestrol, Tibolone, oxybutynin, a medicine commonly used to treat bladder incontinence, reduce the number and severity of hot flashes in women treated for breast cancer. Antidepressants. The most important one here is the venlafaxine, which is a SSNRI, selective serotonin and reuptake inhibitor. Paroxetine is also can be used. Gabapentin and clonidine. Gabapentin has been shown to be more effective than placebo in reducing hot flash frequency. Clonidine is a central acting alpha 2 agonist, has been shown to have modest benefits in hot flash reduction in several studies. Gabapentin, clonidine comes in patches here. CAM therapies. 80% of women in the 45 to 60-year age groups have been reported the use of non-prescription therapies for the management of menopause symptoms. The most famous one is the black cohosh, and this has been approved in Germany for the treatment of hot flashes. The anecdotal experience suggests black cohosh may be 25 to 30% more effective than placebo. Flaxseed is the natural remedy for hot flashes. It's high in omega-3 fatty acids and lignans, which can help reduce the frequency and the severity of the hot flashes. Flaxseed can also help the balance hormone levels and reduce inflammation. Recommended doses is 1 to 2 tablespoons of ground flaxseed per day. Black cohosh and dry roasted flaxseed. Acupuncture has been also suggested as a remedy for hot flashes. Behavioral methods can play also a role in the hot flash management. Something like relaxation, exercises, and paced respirations. This has been shown to decrease the adrenergic tone. Exercise would similarly be beneficial. Acupuncture plus hot flashes, as you see, it reduces the hot flashes. Most famous points are the spleen 6 in the leg and heart 6 in the arm. Relaxation techniques include relaxing music, Tai Chi, guided visualization, progressive muscle relaxation, and deep breathing. At last, there is an injection for intractable cases. Stellate ganglion blocks have been shown to relieve hot flashes by interrupting the sympathetic nervous system fibers that's going to the head and neck area. And usually this is like a last resort type of therapy. Key learning points. Fever, chills, and hot flashes are frequently encountered in palliative care patients. Fever in patients with cancer should be considered indicative of infection, unless proven otherwise. Neutropenic fever is a medical emergency. Fever may be associated with potential metabolic consequences, including dehydration and fatigue, which may be especially pronounced in debilitated, terminally ill patients. Paraneoplastic and drug fevers should be considered in the differential diagnosis of fever. Cytokines are implicated in the etiology of fever secondary to infections and paraneoplastic fevers. Both fever and hyperthermia result in elevation of core body temperature, but they differ in their pathophysiology and management. Many palliative care patients are on drugs that have the potential to cause hyperthermia. Night sweats have also been associated with a variety of medical problems, including malignancies, such as lymphomas, some infections, including TB, autoimmune disease, and drugs. Hot flashes are widely prevalent in some cancers, such as breast and prostate, and postmenopausal women, and may be associated with significant stress. Thank you.